Acha, hi Dr. Shashi. Not Dr. Shashi, hi Shashi. We make everybody doctor.
Yeah. When you are in the company of doctors, you automatically become a doctor.
Doctor, I know. Pradeep, say hi.
Hi.
Oh, wait. No, you have to come ahead.
I had requested Rishikesh to join. Is he joining?
No, I don't think so. That's Pradeep, my husband.
Okay. Nice to see you, sir.
Yeah, nice to see you.
Yeah.
You know Murli or no?
Yeah.
Oh, yeah.
It's a blur.
One sec, I'll just.
Hello, sir. Pradeep, sir.
Yeah, how are you?
Fine, thank you, sir. Come to Sikkim now, sir.
Yeah, I'll come with you this time.
Both of you come.
We'll come, both of us. Really. Okay. You want me to check my presentation?
Yeah. Please check. That's why I told you to join at 7:20.
Yeah, I know. I realize that. I'll just share. 1 minute, huh? Where is this? Near Veena now, which one is this? Why have you opened this? Yeah. Yeah, I think this is the one. Okay.
Yes.
Yeah, so I'll stop sharing. 1 sec. Veena, you've opened one more presentation. Just reduce that. I'll reduce this. This one is the presentation which I want. This one I have to cut. Okay. Yeah. Okay. Now I'm cool. No problem. So we'll start sharp at 7:30.
Yeah, sharp at 7. All our programs, they start sharp at 7.
Very much, sir. Namaskara.
Namaskara. You can start exactly at 7:30, Shashi.
Right, sir. Right. Thank you.
Okay, another 5 minutes is there for you.
Okay, sir. Okay, no issue, sir.
Okay, once you finish your the presentation, then
Right.
there will be.
Okay, fine.
Yeah. Okay.
Sir.
Because we have decided to give in the beginning.
Right,
because
sir.
at the end, what happens is by the time you come on the stage,
sir.
half of the audience will be
disappearing.
hungry and they go for dinner.
Right, sir. Right. ಇವತ್ತು ಗದಗದಲ್ಲಿ ಇದ್ದೀನಿ ಸರ್ ಈಗ. ನಾನು today ಗದಗ I am
but your audio and video is excellent.
sir.
You are looking very smart.
Oh, thank you, sir. Thank you. Now we have started traveling also, sir. Now the traveling was restricted till this month, first beginning. So now this month onwards, they have started.
Corona has come down. What about Corona in Bombay, Nandita? Dr. Nandita.
Yeah, it's much better now because we don't really bother.
Freely moving?
Yeah, freely moving around. In fact, today I walked off the house without a mask without realizing it. Then I went down and I ordered the mask from the house. Because, we've all... It's too tiring. There's
the Corona is not there much, but we are losing great the personalities like Lata Mangeshkar in Mumbai and our own one great literaturist, Dr. Channaveer Kanavi, 92 years old. He was in ICU for 1 month.
Same thing, even Lata Mangeshkar was in ICU for 1 month.
Yeah. And even the singer, he was not there in the hospital, but we lost him, Great singer.
Yeah. But you know what? I think that is the destiny. If it was not Corona, something else would have taken them away. I believe in that.
But see, looking at their capacity to remain in ICU for 1 month, it shows that they were very, very healthy. They could have lived for a long time.
Modern medicine, which keeps them alive. I mean, you have all machines plugged in, no?
Yeah.
Like Pradeep's one friend, he was our age only, but he got some thrombosis kind of a thing, and he fainted in Delhi airport. And he was brought to Bombay, and they switched off all his life support after 1 month. He was kept alive for 1 month,
Very
but
suffering.
could not revive him at all. Then they finally decided they're going to stop the life support. So I think modern medicine also.
Yeah. They also keep them alive.
Yeah.
Hello.
Yes, you can start. You can take 2 minutes more.
Hello. ಬರ್ತಾನೆ 10 ನಿಮಿಷ ಟೈಮ್ ಕೊಡು.
Shashi.
Sir.
Please.
Yeah, you can start.
Program ಇದೆ
Doctor, good evening. This is myself, Shashi sir, sales manager for MCure. And for this, especially for this webinar, I can say it's a Zoom meet. I welcome all the doctors. Dr. Basuraj Sajjan sir, please welcome to the meet. Dr. M.G. Hiremat sir. I also welcome Dr. Muralidhar Rao, Dr. Nandita Madam, Dr. Hema Divakar, Dr. Bharti Rajshekhar, Vidya Doctor, and Dr. Durga Das. Cordially, I invite you everybody for this podium. Once again, thank you very much for giving us an opportunity to host once again this program. Thanks a lot, sir. And we are the basic manufacturers of Oro for XT. This is known to each and every doctor of almost, I think, India. This is the first brand of ferrous ascorbate which has been launched in Oro India. People always come and imitate this brand, sir, because that brand is so much famous. And second molecule, what we have with us is our PAUSE range. PAUSE for a cause. PAUSE is our brand of tranexamic acid, and we are the people behind PAUSE, PAUSE MF, PAUSE XT, and PAUSE injections. Now, recently we have come with one more product, the dihydrogesterone. And the dihydrogesterone, we have this lot of hopes on the brand because of the quality, sir. We are the only people in the market who are doing this same technique what the Abbott is using. That's the SSC XRD technology. So this brand is almost bioequivalent to the original molecule. And I request you, when I get opportunity, and 2 more molecules were there with us for FCM. We have made a separate division for that. Now that has been covered by some other people, some other division people. But majorly, I request for the 3 molecules. Major, once again, before I just close the show, for my side, I request you once again support us for the Dihydrofem, a brand of dihydrogesterone. M.G. Hiremat sir, over to you.
Thank you, Shashi.
Thank you, sir.
Good evening, sir.
Just a minute. Thank you, Shashi.
Thank you, sir.
For continuously sponsoring our academic programs of KCOG almost for last 1 year. Please continue to do so, because this is one way we have identified as the best mode of the giving knowledge at sitting at home comfortably to everyone.
And thanks for
I request Arun to start the prayer.
Thank you, Nandita
Then
madam.
take over Dr. Bharti.
Yes, sir. Thank you, sir.
Arun.
Thank you.
Arun, please play the prayer.
Yes, sir.
शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः.
Namaste and a very warm welcome to our president of KSOGA, Dr. Basuraj Sajjan. I welcome Dr. M.G. Hiremat, our chief veteran, and who is always enthusiastic and pushing us all and sometimes putting us to shame his enthusiasm. Indeed, it is a great moment to have none other than Dr. Nandita Palshetkar with us today. So without wasting much time, I would request our president, Dr. Basuraj Sajjan, to kindly give the welcome address.
Good evening to all. ಎಲ್ಲರಿಗೂ ನನ್ನ ನಮಸ್ಕಾರಗಳು. On behalf of KCOG and KCOG presents a national program. Today, the eminent speaker, Dr. Nandita Palsetkar, the president-elect of ISAR and past president of Foxy, head of IVF unit of Leelavati Hospital, Mumbai. The today's excellent topic, IVF for a better success rate. The chairperson and chief patron of KCOG and KCOG and scientific coordinator, Dr. M.G. Hiramat sir, and convener of this program, Dr. Bharati Rajsekhar, KCOG secretary and dean of this KCOG, Hema Devakar madam, chairman Muralidhar Pai, secretary Vidya Bhatt, treasurer Durga Das, and Manjula joint secretary and web in charge. I welcome all the delegates and all the members of KCOG and KCOG for this excellent webinar. Thank you very much. We welcome all. Thank you.
Thank you, Dr. Basuraj Sajjan. As usual, you're very short, crisp, and a warm welcome to all the guests and as well as the KCOG members. Now I request our chief patron, Dr. M.G. Hiramat, to kindly introduce the guest speaker for today, Dr. Nandita Palsetkar.
Thank you,
Dr.
Bharti.
M.G. Hiramat, sir.
It's always pleasure to introduce Dr. Nandita. As you know that she has a combination of two things. One is beauty, another is brain. And I know her for a very long time, more than 3 decades. And she is a great leader. She has shown in many of our organizations. Basically, she is from Mumbai. She completed her basic MBBS and MD from the Institute of Mumbai, that is Grants Medical College. Right now, she is the medical director of Bloom IVF centers, not just one, more than 8 to 10, distributed in all the major cities of India. She is not only known in India, she is known all over the world as a IVF specialist. And she has got a passion for IVF for the last 25 years. Continuously, she is working to improve the IVF, the techniques and IVF facility at various places. And one of the busiest IVF center is the Leelavati Center, where she is heading that center. And to briefly, all of you know that we know she has worked in so many organizations in our Foxy, and she has visited even Karnataka. Most of the places she has visited as a speaker, and she has many awards to her credit. Received CSR award for contribution in women and child health initiative, and she has received the Indian Medical Association award, inspiring gynecologist of West India, Economic Times award for inspiring gynecologist of India, IMA Empowered Woman award at Chennai, Woman Super Achiever award, Bharat award, and more than that, the most prestigious award, Frost and Sullivan Best Practices Award as IVF Service Provider of the Year. I think if I go on reading her biodata, it runs in pages, and you really know when she completes her talk after 30 to 40 minutes, how depth she has gone into the IVF and how is her passion for that IVF. And today she has selected a very interesting subject. I think many will enjoy her talk. Without taking much time, I request Dr. Nandita to start her talk. Welcome, Nandita.
Thank you very much, Dr. Hiramat. I mean, it's a real pleasure. And thank you. It's a real honor to speak to this August gathering. I think from the bottom of my heart, this is really thank you very much. And respects to you as the chief patron of KCOG, Dr. Basuraj Sajjan, president, Dr. Muralidhar Pai, who's a dear friend and I've known him for so long. Then Dr. Bharati Rajsekhar, who's definitely who's campaigning, and I've known her because before that also, and all the best to you too. So we will definitely be there for you. Then Dr. Vidya Bhatt, who's been in touch with me, and of course, dear friend, Dr. Hema Devakar, with whom I've worked on a lot of projects, with Foxy, FIGO, and a lot of other things. Dr. Durga Das also, who's part of the, your KCOG and KCOG. So thank you. So today I was requested to share my passion of IVF. So that is what I am going to talk about. I love the concept of your skill transfer in the whole program, and I must applaud you all for this program, because I think you're selected speakers who can actually give something back. 1 minute, I need to just reduce the one sec, sorry. Veena, I don't know how to reduce this thing. Can you reduce this column? I don't know, it's gone stuck or something. Is it moving? Let me see. Yeah, the slides are moving. I can.
Stop sharing first.
Yeah, but it's now it's just stop sharing. Yeah, I couldn't stop sharing. Now. Right. Thank you. Yeah. Thank you very much. So I shall begin my talk. 1978 was a year that actually changed everything. Do you know that even Sony invented the Walkman that year, which really made a tremendous, it brought about a change in how we listen to music. It was completely on the run, mobile, and today look where it has reached. We've got iPods, and it's absolutely. So that year, actually, our first IVF baby was also born. So without doubt, it's a technological advance that actually rivaled something like the man walking on the moon. So definitely a lot of things happened in 1978. And we must know that the initial implantation rates when IVF started were only 5% per embryo replaced. And today, at least more than 50% pregnancy rates are there. So 30%, 40%, and euploid embryos have a high implantation rate of 50 to 70%. So I think there were two major complications of IVF that was there: multiple pregnancy rate and the OHSS. And these challenges have been intensively studied, reported. And today, let me tell you, as we go into the next decade of IVF, they are literally completely resolved. So I think this is where IVF is headed. And today it is Make in India, all our units all over. And can you hear me? Yeah. We have all these centers in our country, nearly 2,000 to 3,000 centers all over the country. And we have the ART law, which is actually a fantastic thing which has happened. There are a few problems with the law, but we are going to twitch them. And believe me, see, it is a law. We have to understand that we have to follow it. And today, the live birth rates that we are actually having is anything from 40 to 50%, depending on the patients, definitely. So if you look at infertility, the WHO has defined it beautifully: fail to achieve pregnancy after 12 months of unprotected sex. But remember one thing, that as the patient's age increases, like if she's above 40, you do not wait for so long. You do not wait for more than 3 months or even 6 months. So WHO has also changed the definition depending on age. So this is one point that you must remember. When a couple comes to you, they've just been married and they're 40 years plus, don't wait for more than 3 months to try, after which you must try and help them to get pregnant. So basic investigations, we must remember that we must do a semen analysis. Do not forget the man. Then mid-level progesterone, I don't do it as a rule. Absolutely no. And HSG, I always do, because I would like to know the tubal status of the girl. Baseline ultrasound, ovarian reserve tests have changed. Today, in our practice, we do only AMH, AFC, and the AFC, that's not a CBC, but AFC. And the basic investigations of hormones like prolactin, thyroid, hemoglobin, electrophoresis is something that we do routinely. A rubella IgG screening is done routinely. So this is the basic test that I do in my patients routinely for infertility. So how do we treat them? Treatment options are simple. Ovulation induction with planned relation would be the first. The algorithm goes this way. Then we try IUI. Then if it doesn't work out, IVF, ICSI, donor gametes, and surrogacy. Though now we must, work within the ambit of the surrogacy law. So what is IUI? IUI is you induce ovulation, and then what you need to do is deposit the sperms into the uterine cavity when your ovum is about to rupture. So you time the ovarian ovulation with the sperm insemination. And it's an OPD procedure, takes just about 15 to 20 minutes, and the success rate is anywhere between 10 to 15%. Remember, when you do an IUI, you have to consult the patient. It takes about 3 to 4 cycles. So if your patient is younger than 35, I would do at least 3 to 4 attempts of IUI. If my patient is more than 35, I would just do 2 attempts of IUI. Remember, there was a very beautiful article by, Fast Track. And that actually showed us that in an older patient, if you do CC gonadotropin or CC only or letrozole only, it's better to do that because it's more cost effective than doing only a gonadotropin cycle. And then jump straight to IVF because that is more cost effective. So I'm going to talk about the ovulation induction a little later. So indications of an IUI is simple. Due to abnormal semen, which is very mild male factor. Normally for a moderate to severe male factor, I don't do IUI at all. Unexplained infertility, yes, IUI works. Cervical factors, it gives very good results. Ovulation problems, it gives good results. Semen allergy, it gives good results. Anti-sperm antibodies, good results. Erection and ejaculation disorders, and mild endometriosis. Whereas the next step would be an IVF. So if my patient doesn't conceive with IUI, I would go for IVF. So what are the indications of IVF? Bilateral blocked tubes, severe endometriosis, pelvic inflammatory disease, premature menopause, failed reversal of vasectomy or tubectomy, obstructive azoospermia, genetic disorders, menopause, or surrogacy. In fact, the latest fertility sterility actually has a fertile battle, it is known as. So there are pros and cons of doing ICSI for all. And actually, there are some people who say IVF is good in a lot of patients, and some reproductive endocrinologists who are talking about ICSI is better, and there is no jury out yet. But I think with the ART law coming in, where we will have to justify a lot of things, we will need to be very judicious in which treatment we choose for which patient. So we will have to move towards a more evidence-based therapy in our practice. And I think that these indications of IVF are very important for us to understand. ICSI indications, any kind of male factor, less than 5 million, with oligoasthenoteratozoospermia, definitely go for ICSI. Failed fertilization in IVF, azoospermia, pre-implantation genetic diagnosis, immunological factors, oncology, then ejaculatory dysfunction, paraplegic males, ICSI really works well. Now, actually, did you know, let's go to the male factor. Before 1950, people were not aware that male factor existed. There was no semen analysis done before 1950. This paper by John McLeod was an iconic paper in 1950, where he actually said that the count below 60 billion did not give pregnancies. And that is when male factor was defined. And since then, we have a lot of Like if the semen count is less than 10 million and low motility, then we do IUI. If the total motile sperm count is less than 1 million, you do ICSI. Between 1 to 10 million, IVF would be a good way to go. Post-wash semen count less than 5 million, then I would try medical therapy or go for surgical therapy if it's indicated, like a varicocele or varicocele. Then repeat semen analysis for after 2 to 3 months. If there is improvement, we can go to IUI. If there's no improvement, go for IVF. Remember, in all this algorithm, the woman's age and the AMH is very, very important, because today we are seeing a lot of young girls with low AMH. So it's very important to do the women's age and the AMH along with your male factor infertility and whatever practice you do. So empirical treatments, what we give in idiopathic infertility, if the estrogen is high, when I do a serum estrogen in patients, it's high, then CC, letrozole, and anastrozole really works. And antioxidants, if the DFI is more than 30%, and varicocele correction, if it is clinically palpable. These are the empirical treatments in idiopathic infertility, idiopathic low semen count, or OAT. Now, the personal approach that I have is I follow the WHO guidelines. In fact, there is the latest WHO guideline published in 21, but now it has come in fertility sterility, where the guidelines are similar. But what I follow in my practice is, if according to the WHO guideline, the sperm count is abnormal, I actually go straight for ICSI. So I will have to redefine now with the law coming in, but my personal favorite is ICSI for male factor. IUI or ICSI. If it's if it's normal count, then I go for IUI. So various sperm selection methods are there. See, for sperm selection, remember that you need to have sperms which are intact, which have good acrosomes, which can penetrate the oocyte. So those are important. And today we used to do double density gradient. Density gradient is what we used to do. But now there is further improvement in different processes. And in the lab, I use microfluidics and MAC technology also. And in ICSI, we use IMSI and PICSI. So all these technologies help us in selecting a normal sperm, a non-apoplectic sperm, and with less DNA fragmentation. So in one man, we may do multiple processes. Like I may do microfluidics and IMSI, ICSI, or I may do a MAC, PICSI, ICSI. So remember that in male factor, you must utilize these extra technologies which are available. When the husband has 0 sperms, you can do it by PISA, which is when he has a blockage. So his testes is functioning normally, but there is a block in the vas deferens and the sperms cannot come out. So you can just put a needle in and take out the sperms. Now, again, these sperms can be subjected to density gradient, or even, like PICSI or IMSI. And in sperms with high DNA fragmentation, even if you've given antioxidants, then it's better to go to the testes and remove these sperms, because you will get better sperms. And in patients with repeated ICSI failures, also I do sometimes testicular biopsy. Non-obstructive azoospermia, also we do microtesy. That is microscopic, we see those tubules which are turgid, and those are the ones which are biopsied and sperms are retrieved. And we have a technology called sperm VD today available, where we can freeze 5 sperms, 25 sperms. The number of sperms can be frozen. So it is definitely very, very helpful in cases of non-obstructive azoospermia. So when we have a patient who needs to get pregnant and she's going for IVF, there are certain things which you can do. And this treatment, actually what I'm talking about, can be done even to help her conceive naturally. So if you look at the conditions like PCOS, endometriosis, poor ovarian reserve, hydrosalpinx, male factor, I think male factor I've already discussed what you can do, but let's go to the others like PCOS, obviously weight loss and diet. Now, even if the girl is thin, I think having food with low glycemic index improves the insulin resistance. So that is important because in Indians, a lot of us, have the insulin resistance. And that is why metformin, D-chiroinositol, they really work wonders. Lifestyle modification, including exercise in your lifestyle, is very, very important. A sedentary lifestyle is a no-no. And there's a lot of mental health issues which have been identified by the last international guidelines published in 2018 by the ESHRE, ASRM, and the CREPOS. And those actually talked a lot about the mental issues that are there with these patients. Remember, when you have a PCOS patient, I think send her for therapy also, because a lot of times it definitely helps her when you get a therapist, mental therapist involved with your treatment. So endometriosis, Dynogest pre-treatment is something that I have started using, or OC pre-treatment. I use the antagonist protocol or even the progesterone primed ovarian stimulation, which is latest. I've used it in just 1 or 2 patients, and I freeze all in endometriosis. And if she needs surgery, I would go for surgery, or usually I give GnRH analog 1 or 2 months, depending on the severity of the disease, and then do a frozen thawed embryo transfer. So for endometriosis, if you really want a good result, this is what pre-treatment should be done. Poor ovarian reserve, of course, pre-treatment with adjuvants is a must. Adjuvants that I use are DHEA, melatonin, CoQ, arginine, testosterone gel is something that I use. I use an antagonist protocol with growth hormone. I sometimes use a mild stimulation protocol also. I have done dual stimulation in a lot of patients also. Embryo pooling and a dual trigger is used. I'm going to talk about this subsequently. So the adjuvants is DHEA, testosterone, CoQ, melatonin, and ovarian rejuvenation is something that I will be talking about later.
Please try again.
Hydrosalpinx is something of a real dilemma, because if your patient is going for IVF, I would definitely suggest salpingectomy. In fact, there are a few papers which say even in IUI, if you do a salpingectomy of 1 tube, you'll get better results. But sometimes if pelvis is totally frozen, then tubal clipping helps. And it has been shown if you do a very careful salpingectomy without affecting the ovarian blood flow, you do not affect the AMH much. So you have to be very careful when you're doing a salpingectomy, and tubal clipping definitely does not reduce the ovarian reserve. So IVF plus OPU consists of ovarian stimulation, that's a major part, then monitoring, ovulation trigger, ovum pickup, an IVF ICSI, and embryo transfer. This actually takes about 14 days. And remember that nowadays during COVID, when I start, I actually do D-dimer and serum fibrinogen and coagulation profile of most of the patients before taking them on. And even post-vaccine, it's important to do these. But now I'm finding the disease has become milder, and we are not seeing much of the disease. As I was discussing with Dr. Iriamat, that Bombay is definitely dropped down, and people are not testing. So we test all our patients. We are not getting so many positives at all now, and patients are not getting cancelled at all. Because in between, when the Omicron January or something, I think we had nearly 50-60% of our cycles cancelled because of Omicron virus. So ICSI is, the injection of the sperm into the oocyte. So sperm preparation, as I talked to you about density gradient centrifugation. But remember 2-3 things of points of practical thing is the husband should have as less abstinence as possible. In fact, if it's a low count, even 1 day abstinence is good. So 2 to 3 days abstinence is what I insist on in all my patients for IUI or for IVF. Then the container should be warm or not at least cold, because it really minimizes the risk of cold shot. And that day, my patient had a viscous semen. So please put media and give him to ejaculate into the container. So these are the things that you must remember. Then you come to the ovulation induction, which is clomiphene citrate, which is the commonest one which we use for IUI. I think it's a very standard, which I use for all my patients, except PCOS, I've started using letrozole. So instead of clomiphene, I use letrozole 5 milligrams per day. And usually I start from day 2 for 5 days, either clomiphene or letrozole. As I've told you, the doses are 100 milligrams or 5 milligrams. And letrozole is my first choice in PCOS patients, and clomiphene is my first choice in all the other patients. Ovulation trigger is given when the leading follicle becomes 18 to 20 mm, and then luteal phase support I give when the ovulation, after the 1 day after ovulation. So in an IUI, if I want to add gonadotropins, I normally add gonadotropins on day 7. Every day. So 75 international units, either HMG or FSH. So you've given CC or letrozole for 5 days, and then you add gonadotropins. And what it does is, instead of giving full gonadotropins, if you add gonadotropins only for 3 to 4 days, it lowers your cost and gives you similar pregnancy rate. But remember that the multiple pregnancy rate may be a little higher. And if you have a premature LH surge, you can add an antagonist over here. Premature LH surge can be ascertained by doing urine LH kits, or what I do is, if 2 cycles of clomiphene plus gonadotropins don't work out, then I add the antagonist without checking for the premature LH surge. Because Friedman has showed that nearly 15% of the cycles have a premature LH surge. The antagonist protocol is very simple, which we use for IVF or in PCOS patients. You start gonadotropins on day 2 and continue every day. You add antagonist, flexible antagonist, when the leading follicle is 14 mm, and when the once that leading follicle reaches 18 mm, you give the trigger, which is an HCG or a GnRH agonist, and then you do the ovum pickup 36 hours, or you do an IUI after 36 hours. So this protocol basically remains the same, only the dose varies. And I'm going to give you the chart of the dose in the after 2-3 slides. So this is the simple protocol which all of us must remember. This is GnRH, you give FSH or HMG throughout, and add the antagonist to the protocol. This is for IVF. The mild stimulation protocol is the one which I mentioned before, CC plus FSH and with antagonist. The long protocol used to be used before. I do not use it in my practice at all. I've just put it here because a lot of students were going to be there. That's what Dr. Vidya told me. So yes, you do start it in the luteal phase of the previous cycle, and you can add the analog and suppress luteal suppression, and then add the FSH from day 2. You don't need but you cannot. You have to trigger with HCG, and the chance of hyperstimulation is very, very high in this protocol. So in my practice, I have literally stopped using this protocol. So this is the chart which I follow. What are the points that I consider? Age, the antral follicle count, and the AMH. I think that is the most important thing. And as time goes by, we will do genetic studies. We'll know the FSH receptor polymorphisms. We'll know the SNPs, and we'll modify individualized stimulation. But so far today, till now, you consider age, AFC, and AMH, and you increase the dose accordingly. So this is how I do it for IUI. And for IVF, I start straight with 150 and then increase it by 75. So for PCOS, I would do 150, and then more than 35, 225. For normal responders, I would start with 150, 225, 300. And for poor responders, I would start with 300, 375, and 450 for IVF. But this is how I go in an IUI cycle. And you saw the AMH levels. Less than 2 nanograms, normal responder is 2 to 3.5, and a hyper responder is more than 3 nanograms. monitoring of the patient has to be kept very minimal so that you make it very patient friendly. Unless it's a research paper where I'm doing a study, I don't do extra blood tests and all at all. So serial transvaginal ultrasound is the only monitoring that I do. Day 2, day 8, day 10, and then trigger. That's all I do for IUI. For IVF, I would do day 2, day 6, day 8, day 10, and trigger on day 10. So that's all that you need to do. All these estradiol level, LH level, this is all in, if I'm doing a study or if I'm doing a research clinical study, then only I do it. Otherwise, I only do a transvaginal sonography. The trigger that is normally used in my unit is HCG, 5,000 to 10,000, or I use a recombinant, which is 250 micrograms. But most of the times in a hyper-responder patient, AMH more than 3.5, I use a GnRH agonist. 1 milligram of leuprolide or decapeptyl is also what I use. Now, remember, when you're doing the OPU, it's very simple. We do not use any betadine or anything to clean. We use normal saline. But, if you're going to do flushing and all, then remember that you must use betadine. But it must be very, very carefully washed out so that you don't have any traces of betadine present at all. Okay, then the second thing that you have to be careful of when you're doing the pickup is, when you put the needle in, don't keep moving your probe because then you will tear the vagina. So you take all the follicles in one line only. So you go from one to the second to the third. Remember that. And when there are difficult OPUs, take extra care while doing OPUs in the following cases, like many follicles or very few follicles, because the vessel is there. Always move the probe and see. So if it becomes transverse, that means it's a vessel. Okay, if it doesn't, that means it's a follicle. So in cases of many follicles, you must be careful that because you become very close. Then very thin patient and very obese patients, highly placed ovaries in the pelvis. So somebody should put their hand and get the ovary down. Then associated pathology like PID, endometriosis. If you have a patient of endometriosis for pickup, please admit her, give her 24 to 48 hours IV antibiotics. If you punctured the endometriotic cyst, give her 48 hours IV antibiotics. Hydrosalpinx, if you've punctured it, again, IV antibiotics is very important. Then fibroids, sometimes you go through the fibroid adenomyosis. You have to be a little, careful. Then fibrosed vagina, fibrosed ovaries, lax vagina, hypermobile ovaries, hyperstimulated ovaries, previous LSCS, specific counseling regarding pre and post OPU, abstinence is very important, and secondary hemorrhage is also very, very important. Now, if you come to the laboratory, what is important is the air handling unit. In the ESHRE came up with the guidelines that the air handling unit must be present, and a lot of units shut down in Europe. And I think the air handling unit really brought up our pregnancy rates. We didn't have an air handling unit till about 20 years ago. And our pregnancy rate, which was stuck at 30%, jumped to 50 to 60% after the air handling unit. So air handling unit is really very, very important. Then integrated workstations are really something that has made IVF very good and cost effective. Multiple incubators. IVF lab with multiple incubators will always give you better results. And remember, when I have one patient with many eggs, I always put them in different incubators. Reduced oxygen tension. We used to use 6% oxygen. With the 5%, you're getting good pregnancy rate. Improved culture media. I think with the addition of all the factors, then the blastocyst culture media, the different sequential medias, and now you can add different inotropes, etc., to the different medias. I think that has improved the pregnancy rates also. Then co-cultures, hatching, embryoscope. All those are really good. And if you really have a good lab, you should have a pregnancy rate which is minimum 30%. If you have anything less than that, I think a quality check, troubleshooting must be done in your lab. Sperm morphology and MC, this was a beautiful technology introduced by Bartov in, I think, 2003, where the sperm is magnified. If you can see the lower picture, 6,600 times. You can actually see the head, the cytoplasmic inclusions, and you can measure the head and the diameter, I mean, the width and the length of the head and the tail, and see everything and pick up the normal sperms. This is another technology, the poloscope, where you can actually identify the spindle. Usually the spindle is near the the pronuclei. And you remember that we always keep the pronuclei at 6 o'clock or at 12 o'clock while injecting for this reason. But remember, when you have patients of cancer, where you've frozen only 8 eggs and you don't want to damage any, because at least 10 to 15% of the eggs have a spindle which is not near the polar body. And that's why this instrument, you can do the injection while identifying the spindle. The previous technology, you couldn't keep it, you couldn't switch the lenses. Now here you can identify the spindle and then switch the lens and do the ICSI injection simultaneously. So this is how technology has worked its way into the lab and given us better results. Okay, blastocyst transfer definitely improves pregnancy rate. Double transfer is really something that we've been doing and have got good pregnancy rates. That's something I would advocate to a lot of failure patients. Assisted hatching is something I've been using for a long time. Good pregnancy rate. Then the embryo transfer. I think using an ultrasound, using both your hands, minimum time, the lab should be next to the ET room is very, very important. Cleaning with normal saline and as atraumatic as possible is very, very important. Soft catheters are extremely important. Wow, I knew this will happen. Veena, please come. Okay. Then freezing has really improved the pregnancy rates, and that has really brought about a change. No, I managed. Thank you. So the vitrification technology is superb. It has brought the pregnancy rates up to 50 to 60% that I talk about. But freeze-all is a technology which should be used only in hyper responders, because in normal responders and poor responders, it gives the same result. So remember, one thing I've learned over 30 years of experience is don't do too much. Do as little as you can for the embryo. So if you can do a fresh transfer, I prefer doing it the fresh transfer, because I am doing as little manipulation with the embryo as possible. Selecting the best embryo is also important. So the time-lapse photography or the embryoscope, and there are fabulous algorithms which are available now, which can help you select the best embryo, and it's a beautiful incubator. Then pre-implantation genetic testing also with the new platform of NGS. See, PGT-A is aneuploidy. So the numerical errors of all your 46 chromosomes can be done. So if there are, it's XX, XXX or XO, or there are triple, Turners or Downs, trisomy 21, you can actually do with PGT-A. PGT-M is monogenic, single gene disorders, cystic fibrosis, BRCA, or even thalassemia. All those genes are with PGT-M. And PGT-SR is structural rearrangements, like, Robertsonian's translocation, etc. So these are the three arms. And now there is a new one called PGT-P. And that is so superb. Can you imagine? There is a genetic lab in US which is marketing intelligence score with the PGT-P. So you can actually identify the intelligence of your baby along with diabetic risk, which are polygenic diseases. P means polygenic. So diabetic risk, the hypertensive risk, and also intelligence scoring. Of course, there's a lot of ethical debate going on about it, and only one company in America is marketing it, but it is also soon going to be available. So PGT is generally performed on polar body, blastomere, or trophectoderm. What we do is blastocyst trophectoderm biopsy. 5 to 10 cells from the trophectoderm are taken, which is generally what gives rise to the placenta, and that is given for testing. Okay, then now the latest that I have in my lab is non-invasive chromosomal screening. So what does it mean? That the blastocyst is growing in this media. So it secretes its DNA into the media. And this media is taken, and there's Malbec, it's subjected to Malbec. This is, amplification and looping and annealing and lots of process, and then it is subjected to the NGS platform, and you can actually identify all the chromosomes. It's like your NIPT. So we can actually identify the embryo's genomics without touching that embryo. So it's a fantastic technology. And today the concordance is as high as 84%. I talked about it in 2016 at the IFS conference in Noida. But today we actually have in reality, and we're doing it, and it's amazing. The future, fertility preservation, creating gametes from stem cells, uterine transplantation, overcoming mitochondrial disease, augmenting oocyte quality, and editing abnormal embryos. I think fertility preservation, we all know, for cancer patients, for social freezing. In fact, the ART law also has come in where it's talking about social freezing, cancer preservation, etc. So you can preserve the eggs, you can preserve the embryos, and you can preserve the ovarian tissue also. And remember, preservation is not only for social freezing and cancer, but patients of endometriosis, patients of poor ovarian reserve, you can freeze, patients with tuberculosis, genital tuberculosis, and patients with repeated dermoid cysts, repeated cystectomies for benign cystadenomas. You won't believe it. The other day I did a video consult with a girl. She said, I'm PCOS, my AMH is 9, and I'm 26 years old, and I want to preserve my eggs. I said, why do you want to preserve so early? We can keep watching your AMH. No, but I know that PCOS, you get bad eggs. So I would prefer, because my quality will deteriorate with age, I would prefer to preserve my eggs as I'm younger. I mean, it set my mind thinking. I'd never thought of it this way. So a lot of applications, out of the box thinking. So I'm going to apply precision medicine to this girl. If the precision medicine, where we study 200 to 300 genes, they tell me that she has chances of bad eggs and aneuploidy in the eggs, then it's good to preserve eggs while she's young. So see, the applications are really changing. Creating gametes from stem cells, I mean, that is the future. But uterus transplantation is a reality today. We have uterus transplantation going on in our country. In fact, I'm on the uterus transplantation committee of Maharashtra state, and we've done so many transplants. There's a huge waiting list, and with the surrogacy law becoming so strict, so probably a lot of uterus transplantation may become more popular now. And we are trying to get the cadaveric transplantation in process. Then overcoming mitochondrial disease, I think Nuno Costas and Johnny Zhang are two people who have actually worked a lot in it. I don't want to go into details, but you can actually pick up the DNA and put it into a younger woman's, where she doesn't, the cytoplasmic mitochondria do not carry the mitochondrial disease. So you can actually overcome that. Then augmenting oocyte quality, you can actually take mitochondria and insert it into the cytoplasm or use a donor cytoplasm. Editing abnormal embryos, that is the most beautiful part. I think CRISPR, in fact, we are looking at a lot of things where ovarian cancer, you can edit the cells so that they become more responsive to certain drugs. So CRISPR is really working its way into medicine. And soon we may be, instead of throwing away abnormal embryos, we may be able to edit those embryos and make them normal and to use them to have progeny. So this is the future of ART. And I would really like to say thank you to everybody for giving me this opportunity. I think I really enjoyed talking to all of you all. I have cut my talk in short because it's already 45 minutes. So I have decided that I will, I can go on talking for 2 hours. My son made this talk, Rohan made this talk. I said 79 slides. He's saying, Mom, you'll talk for 2 hours. You please stop.
You can talk without slides more, I think.
Anybody would like to comment? Murli?
No, it was excellent, Dr. Nandita. You gave a total view of your 30 years of experience. So many changes happened, but you nicely explained everything, how things evolved from one to another up to PGT. And then you had your own personal tips, what you gave. And those were really very, very practical tips, and nothing like that coming from you, because many people don't have to reinvent the wheel. They can straight away take your tips, especially the youngsters. So it was wonderful.
Thank you. Shobha Gudi, would you like to comment? Dr. Shobha Gudi.
Of course, Hiremat sir. She was the first president that I worked under as chairperson.
Anybody else?
And what an year that was. It was really fabulous.
Bharti has got some questions.
Leader.
Bharti, you can ask those questions.
Yeah. Nandita, a very good presentation. Excellent presentation. Yeah.
Thank you. Thank you.
Thank you, Dr.
I think
Nandita.
I was not audible. Yeah. Thank you.
It was indeed a privilege to have you with KCOG today in our national program. And as Dr. Murli rightly said, those practical tips which you so nicely put across, saying that if it was just to present a paper or for academic research, you would do the estradiol and other levels. But for us, practically clinicians who work in the private sector and working in seeing a low middle income group patients coming inside. And as you said, just looking at the transvaginal scan is how we decide on the dosage of the medicines, because every single injection costs, makes a huge difference for the population whom we cater to. I think these things go a long way for our clinicians who are working in smaller hospitals. And we thank you very much for giving us these tips. And I would like to, again, on this platform, try to request all my KCOGians that we know that Nandita Palshetkar is an eminent clinician as well as an academician who is contesting for the FIGO representative from FOXY. I request all of you to support her. And at the same platform, I would sincerely request all of you to support
me also.
Nomination, which I have put my nomination for the chairperson of the Family Welfare Committee, which Dr. Shobha Gudi is doing a wonderful job, and we hope that the baton is passed on within our state.
Thank you.
So I request all of you to support us, and I think I request any other people. Dr. Vidya Topi is there, Dr. Durga Das is there, and you could give your comments, and then we will conclude the session.
Thank you, Bharti. Thank you very much. Nandita, your talk was excellent, and you have sticked on to the timing of 45 minutes. I know it's very difficult to cover so much of infertility in just 45 minutes, but you have touched almost all the aspects like basic evaluation of the couple and tips for the quality, maintaining the quality of the lab. I think that is the one which really is very much needed, that as your lab quality is good, your success rate is always good, and self-checking is very, very important. And difficulty in techniques also you already mentioned. And your protocol of drugs also you have given very good tips, because a lot of confusion is there for many people. Every case you have to select your own the drug combination, which you already given. And pre-implantation genetics, you have told all the available things, including the new technique, which is a dream technique. I don't think I can invest that in my IVF center at Hubli. I think only in places like your center can invest such a high one. But still, these are the new things which have evolved in a very, I think infertility is one subject which is ever expanding. As you go on doing more and more, you feel that you are not knowing much also. I think this is a subject which is very much passionate to many of us, and we really thank from my bottom of heart for selecting and accepting our invitation in a very short time, because this is the program we just devised, and you are the first speaker for this program. The KCOG National program was not there earlier. This is first time we have introduced, and as you know that our KCOG KCOG programs will be happening on every Thursday. Almost more than 50 to 60 national luminaries have come on this stage, and international program will be there next week, Thursday. Dr. Hema, our dean, will be conducting that. And I think this is a new program we have introduced, and you being the first speaker, really it has been given a good impetus to this program. Thank you very much, Nandita, for the excellent talk and excellent presentation of the topic. And we all know that you are right from the basic, you are there, and you are one of the Indian who has taken up this subject 30 years back. And really now you are in the stage where you must represent India at international level. So as rightly told by Bharti, that we would like to support you in this endeavor. Hope you will come with flying colors. Thank you very much. I request our treasurer, Dr. Durga Das, to give the vote of thanks and his comments.
Good evening, everybody. Dr. Nandita Palshekar, thank you very much for taking time in your busy schedule to address us. Your talk was very nice. We are all regular gynec practitioners doing our regular infertility, practice. Infertility treatment is one among them. Your talk has given lots of practical tips to us, and also newer developments coming up in infertility. I think Dr. Nandita has a special affection to Karnataka. She has taken her president post as Foxy in Bangalore AICOG. In the meantime, I say we wish you are in the same platform. You also become figure representative from Foxy. This is our wish from Karnataka. Thank you very much for taking time to join us today.
Thank you.
I also thank our chief patron, Dr. Hiremat. I also thank our president, Dr. Basavaraj Sajjan, our secretary, Dr. Bharati Rajshekar, our dean, Dr. Hema Devakar, chairperson of KCOG, Dr. Muralidhar Pai, secretary, Dr. Vidya Bhatt. I also thank all the delegates of today, and also thank the MCure for supporting this program. Thank you very much.
Once again, thank you. I would like to thank many of the participants here. Manjula Patil, Sharan, Shobha, Shavi, Beena, Asit, Kavya, Pradeep, Madhuri, Kammar, Seren, Saraswati. Vidya Tobbi, madam, would you like to speak something, Vidya?
Very silent.
Vidya has become very silent.
It's a photo, I think.
Manjula Patil?
We have taken the photos.
Yeah. Anybody else?
Yeah, Dr. Hiremat sir, I would like to say, Dr. Nandita really brought out the ovum pickups, no? Those final points. Really, I felt that youngsters will benefit a lot. So kept the talk both for the fundamental, the basics, and the pharmacotherapy of ovulation induction, as well as the most advanced. So I felt it was really very comprehensive. Thank you, Nandita, for the time.
Wishing you all the very best, ma'am.
Good evening. Anybody else? We have some time. That's why I'm inviting. Another 5 minutes time is there.
Dr. Nandita, I had a question. How do you decide on the trigger whether you want to give 5,000 or 10,000 units of HCG?
Nandita, audio is not coming.
You're muted.
Nandita, audio.
Yeah. Can you hear me now? Yeah.
Yeah.
My routine practice is usually 10,000. But now what has happened is in IVF now, whenever there is anybody who's got follicles more than 10, I get NRH analog. Or if it's a very thin patient, AMH is high. A poor responder sometimes, with more than 6-7 follicles, I just tend to give GnRH analog because safety comes really is something that you need to take care of. And that is what is really important. So the OHSS safety has come with GnRH analog trigger. So once in a while, I have had 1 or 2 patients bomb over the last couple of years that have started using GnRH agonist trigger. But it is not to give GnRH agonist trigger because for those 2 patients, I have not put thousands in danger. So I think whenever you're doing use GnRH agonist trigger. For IUI, I think 5,000 is a safe dose because the lesser dose you use, the lesser is the OHSS chance. But for IUI, if you want to prevent, more multiple pregnancy rate to be less than 2 follicles, 2 or less than 2 is what you should do IUI.
So there's another question from Dr. Kavya. There's a female with good ovarian reserve and male factor semen analysis showing 8 million, count with 100% immotile sperms with 30% viability, varicocele ruled out, hormonal assay normal, how to proceed and whether TISA helps in such patients.
No, this is ICSI. You do HOS test. I didn't go into too much details, but the hyperosmotic swelling test can be done while we do ICSI. So when the tail, whichever the sperms have the curling of the tail, you take that and you inject those sperms. So it is just a hypertonic saline which you put in, into that droplet of ICSI, where you put PVP. So along with the PVP droplet, you put hypertonic saline. And if the tail curls, you pick up those sperms. So those are viable sperms.
Okay, got it.
Put in the other droplet and inject it. So it's very good patient. 30%.
Yeah, that's a good tip.
Yeah, 30%. Good.
Those who have muted their videos, they can on their videos so that we will see you. Quite a good number of them are there, but they have all muted their videos.
Dr. MG Hiram, most of these webinars which we are sitting at home after a busy day, we don't want to put on our videos because I just came back from Bangalore with my grandchildren without my daughter. So
I will show your grandchildren, no problem. Anybody else? Thank you.
My granddaughter had a question. She said, "What are you talking about?" I said, "We're talking about women's health." She said, "Why are you not talking about men's health?"
But both health today.
Okay. Shobha Dhananjaya, madam.
There is a question by Dr. Geeta Bharat. Madam, experience on transmyometrial embryo transfer. I've done only one. It's the Tovaco catheter, I think. Yeah. And it was horrible. But if you have to do it, you have to do it. It's got a 25% pregnancy rate. But really bad. But I think, what, we really did try a lot of other ways. But if you just go in with that catheter, go transmyometrial, I think it would work well. Tovaco, you have to order it before. It's available if you order it.
So I think, sir, we are spot on time.
Yes,
and again,
okay.
Good night to all of you.
Thank you. Good night.
Thanks, Dr. Nandita.
Thank you.
Wishing you all the best.
For the excellent
All the
talk.
best.
Namaste, sir. Sorry, sir. Hi.
Thank